Hello, everyone. Wanted to get the GI lecture out there for you. So, GI alterations. There is no part two, so don't worry about looking for a part two. So, what does our GI tract do? We ingest food, it propulses that food and waste from one end to the other. It secretes mucus, water, and enzymes, digests food by the um, pulsing of the digestion tract. It also does chemical digestion of food, absorption. That's where we get a lot of our nutrients. And then it eliminates all of our waste products. So starts at one end and goes all the way to the other. So we kind of start out with going through some common lab tests. Uh, Blood tests that we might see when someone comes in with stomach pain or any other GI issues. They might have a CBC, which a CBC includes the red blood cells, the white blood cells, hematocrit. Red blood cells, they're looking for anemia. Same with hemoglobin, hematocrit. They might be bleeding somewhere in the GI tract. That's generally how they find a GI bleed. And white count is looking for any type of infection. A lot of times electrolytes will be drawn, specifically calcium, potassium, chloride, and sodium. And then you might also see a fecal analysis. This is looking for blood. You can do occult blood. They might be looking for ova and parasites. They might be doing things like stool cultures. Might be looking for lipids in the stool, and then also a C. diff, especially if they're having lots of diarrhea and they've been on an antibiotic or three, and their diarrhea is just not clearing on its own. Or once you see C. diff, if you haven't already, you will never forget it. It'll always be that once you see it, you can pretty much diagnose it by the second time you see it. So, diagnostic procedures. There's lots of different things. Flat plate of the belly of the abdomen. Just an X-ray, looking for stool or gas, maybe a bowel obstruction, maybe just constipation. This is what when the kids come in with stomach pain, they're going to do a flat plate right away, just to see if they're constipated or if there's any free air or gas in the belly. Could be flat, could be upright, just kind of depends on what the doctor prefers. Then there's an upper GI series where they will go down with a camera so they can see the stomach, the duodenum, and the jejunum. This is when these guys are NPO 6 to 8 hours before procedure, and they're just kind of looking to see if they can actually visualize anything, any issues in the upper GI portion. A lower GI series, they're looking at the colon. They have to have a low residue diet 2 days before the procedure, and they are prescribed. It used to be Glow Lightly, and now a lot of docs have actually gone to Miralax, but it's like a whole bottle of Miralax in one night, so you can imagine how much these guys are going. Most people just live on the toilet for the night. A lot of people I've seen people get commodes so they didn't have to make it all the way to the bathroom if they're trying to sleep. And obviously they're NPO. CT, they might do a CT if they do an X-ray of the belly and need a closer look. So they're looking at differentiating if it's a mass or a tumor, or if it's just part of the normal bowel, normal intestines, normal abdominal cavity. Ultrasounds are done to look at the gallbladder, the appendix, and some other soft tissues in the belly. Nuclear scanning, that looks for biliary disease. Endoscopy, They actually go in and might remove polyps, take biopsies, and they might burn the bleeders if they have a GI bleed. They might go in and burn those so they stop bleeding. Angiographies are done to look for cancers of the gallbladder, the liver, and the pancreas. All right. EGDs is basically kind of like an upper GI series where these guys are NPO, they're given a sedative. This big camera tube is gone through the mouth, and they'll look at everything. You can see where there's an ulcer in that picture on the right hand side. They are NPO until their gag reflex returns. Generally, they'll have this back before they even leave. I know they're done in GI and infusion in Viroqua, but before they even leave, they have their gag reflex back and they've drank some juice and a piece of toast. They are at risk for perforation. I have seen it where the doctor is trying to get through the twists and turns and actually perfed. ERCP, it's called an endoscopic retrograde. Yeah, I'm not even going to try that anymore. Anyways, the ERCP looks at the liver, the gallbladder, and the pancreas. Again, we got to ask if they have any allergies to iodine and shellfish. Don't forget the shellfish part. Their NPO, same thing as an EGD, but a lot of times they do an MRI instead of an ERCP. Sigmoidoscopy, they're looking at the distal sigmoid colon, the rectum, and the anus. And a colonoscopy is where they're looking at the large intestine. So all four of these are where they pass a camera. An EGD is passing from the top. ERCP, sigmoidoscopy, and colonoscopy are all pass it from the bottom. They are sedated for this. Some people choose not to have any sedation. Some people choose to have maybe very light sedation just because of waking up from it. Maybe they have an issue. So I do have some friends that they're the ones that actually work in GI, and they actually do colonoscopy without any sedation. Wouldn't be me. Please knock me out. I don't want to know anything that happens. Some interventions, nursing interventions related to the GI. Tube feedings. They are used to give nutrients or supplements when people can't take anything in orally. These are the NG tubes. I can't say that, esophagostomy, gastrostomy, and jejunostomy tubes. Just kind of depends on where the end of the tube ends up. Is what the type of it is called. Can be gravity and can be pump. I've done both. A lot of times it looks kind of like an IV bag that you pour the formula into and it just hangs gravity. Otherwise it's kind of like an IV pump, kind of set up kind of the same way. These tubes might also be used for lavage. So gavage is feeding and lavage is actually pulling something out of the stomach. So they might irrigate the stomach where they put in fluid and then suck it back out. Maybe they have a bowel obstruction and they need to decompress the stomach. So it gets rid of the air and the fluid sitting on top of the obstruction. Levin tube, Salem sump pump are a couple of the types. You guys will get into more of the NG tubes in third semester in skills. We actually learned how to insert them in skills, and they're really not as scary as they seem right now. All right. I'm sorry this slide is kind of messed up. So there is TPN, which is called total parenteral nutrition, and there's PPN, which is the peripheral or partial parenteral nutrition. So TPN must use a central IV line. The fluids are hypertonic, so it can actually cause damage to the veins if they're done with a peripheral IV. TPN is very highly concentrated, and the glucose really needs to be monitored on these people. Generally, it's taken about every 6 hours, I believe. Just kind of depends on what the policy of the facility is, but it's watched very, very closely. TPN is also hard on the kidneys and the liver. CBCs will be done, electrolytes will be done, just to make sure that they're getting all the supplements and everything is working just right. Generally, TPN is started pretty slow, and they're actually weaned off of it. So they'll slow down the infusion of the TPN and have them kind of start eating small amounts. Like I said, it's really their glucose is pretty much fluctuates even if somebody is not diabetic. With TPN, a lot of times they're given insulin. TPN is mixed, TPN and PPN actually, but they are mixed by a pharmacist. They get the formula that each patient needs based on weight, based on their albumin levels, based on a lot of other things. Put this formula together and they mix up the TPN. Risks for TPN. These guys are at a huge risk for fluid overload, pulmonary edema, CHF, because it is a lot of fluid going in. So what are we going to do? We are going to make sure we're doing daily weights on these folks and strict INO. And then, like I said, we're going to monitor those electrolytes really close, specifically the potassium and the sodium. PPN, this is a very short-term fix to nutritional deficiencies. This is when people can still eat. So TPN is they are eating nothing orally. PPN is where they're eating small amounts orally. So PPN is used for less than 10 days, provides less than 2,000 calories a day. So they're going to, whatever they're eating, this will be added to their oral calorie intake. Sugar is minimal in the PPN, so it can be administered through a peripheral IV, a regular IV. All right. Moving on to obesity. Obesity is figured when somebody is 20% over their ideal body weight, their body mass index, their BMI. It says up here the waist to hip ratio, but they generally go off the BMI. So morbid obesity is considered anything greater than 40 BMI. Overweight is considered anywhere from 25 to 29. So you can kind of see where that all fits in. So it's overweight is 25 to 29, obese is 30 to 39, and morbidly obese is 40 and above. When somebody is obese, we have to rule out other causes. So maybe someone has a thyroid disease where they're hypothyroid and everything is slowing down. That might be a cause for obesity. Other things that we need to look at for causes for obesity are their diets. If they're taking in a high fat, high cholesterol diet, they're going to be obese. If somebody is physically inactive or has a very sedentary lifestyle where they're not up and moving around or exercising, and then sometimes drug therapy can actually be a cause for obesity. drugs like corticosteroids, like prednisone, NSAIDs, antihypertensives can actually cause people to gain weight. Antidepressants can cause weight gain, and anti-epileptics can cause weight gain. Specifically, Depakote. I've seen that. That's a huge risk for weight gain. But you have to look at the benefits versus the side effects. So, management. Obviously, weight loss programs like Weight Watchers is one of the most uh, well-known ones. Uh, the nutritionist can meet with these folks, have a consult with them. They can have appetite suppressants, increased activity, so they're exercising more. There's lots of newfangled things out there, whether they're pills, whether they're, I don't know, Sparks, I think, is a weight loss thing. I don't know. I don't know a whole lot about, I don't diet and I don't try to lose weight. So, what else? Obesity related diseases. Depending on where a person carries their weight, actually can be a precursor or a red flag for certain types of health diseases. So, like anything where the person carries most of the weight around their stomach, like their stomach area, they're at a huge risk for type 2 diabetes and anything cardiac and sleep apnea. Um, what else did I forget? Yeah, coronary artery disease. They're actually higher risk for stroke when they carry their weight around their belly. Yeah. All right, so surgical management of obesity. The bariatric weight loss surgery has really increased. I think it came out in, I don't know, early 90s. Not many people had it. And now I think a lot of everybody's had it, I guess. At least I know several people that have had it. Uh, some people it works wonders for, and some people they give up. I have a friend, Jimmy, who had it done, and he said he didn't like being skinny, so he went back to all of his old eating habits. Whereas my friend Amanda had it done, and she looks amazing, and she is the most healthy eater I've ever met in my life. She must have lost, I don't know, she lost a lot of weight, and she looks super. So it is a good thing that this came out. It really helps a lot of people. I know my cousin said for the first time she was able to take her boys sledding, and they were older, but they'd never been sledding with their mom, so they actually went on a sledding trip. It was really neat. All right, so anyways, gastric bypass is probably the most common one that we hear about. It's called a Roux-en-Y. So there's a banding and malabsorption strategies used. So instead of going down the esophagus and into the stomach, they literally link off a very small part of the stomach that only holds about an ounce, band that off, and then take and bypass the rest of the stomach and make a new flow so they literally can only put about an ounce of food in their stomach at a time. So that's where these people gain weight. If the person has a stomach the size of an ounce and they keep eating like event or over time they eat more and more and more, it'll just stretch that stomach out. So they honestly don't keep the weight off. It all comes back because they've stretched their stomach out. In a Roux-en-Y procedure, 90% of the stomach and duodenum and part of the jejunum is bypassed. 90% of that. So they're only able to absorb this 10% of what they used to. So they can't absorb the calories, they can't absorb the fats. It's just basically a quicker way through the stomach. Restrictive surgery, this is a lot less invasive. It's a laparoscopic procedure where they actually put a binding around the stomach. It makes the stomach smaller, but there's these people really have to follow their diet restrictions. Again, because they'll overstretch that pouch that was made based with the banding. All right, benefits of this weight loss. When these folks have this surgery and lose the weight, they can actually resolve type 2 diabetes. Remember I said some people that carry their weight around their belly are a huge risk for diabetes? Well, once they lose that weight, it can actually resolve, which is really kind of cool. Again, with this weight again, lower their heart risk disease, gallbladder disease, DJD, sleep apnea will decrease, their blood pressure will get better, and just an improved quality of life. Like I told you, my cousin went sledding with her boys. She'd always wanted to do it when her kids were younger and was never able to because she was too big and she couldn't get back up the hill. And if she got in the sled, she couldn't get back up. But the quality of life for these folks is life changing. But there are problems with this weight loss surgery. Sometimes there's coping issues. They do have to go through a quite lengthy psychiatric evaluation before they have this surgery. Sometimes they might have coping issues because they're just don't do well with the new diet and the new lifestyle, because it is a lifestyle change. You can't just say I want to eat Twinkies before and after my surgery, because your surgery will basically be null and void and you'll gain all the weight back. So it is a lifestyle change, and sometimes people have a hard time coping with it. One of the biggest risks or problems with this bariatric weight loss surgery, it's called dumping syndrome, and we'll get into it. I think it's actually in the next slide, so I don't want to get into too much. But sugar, high carbs, and when people drink fluid, like they'll eat a couple bites, they'll drink fluid, they eat a couple more bites, drink fluid, that worsens the dumping syndrome. Symptoms with dumping syndrome are things like tachycardia, nausea, diarrhea, abdominal cramping. So sometimes these folks have nutritional deficiencies. I've seen people who, after the surgery, they couldn't eat anything, so they decided to drink, and so they drank beer. Obviously, that is lacking all the nutrition that they really need, and sometimes the body's just not absorbing what it should in that 10% that's still there, usable. And again, the lifestyle changes. They always have to monitor their weight and make sure they're monitoring what they're taking in their nutrition. Other things that we worry about is a wound dehiscence, especially with the Roux-en-Y surgery. Anytime there is a stomach surgery, there's a huge risk for dehiscence. And I don't know the specifics as to why stomach surgeries are like this, just because they're moving around. But there is risk for wound dehiscence. So these folks will have the abdominal binder on just to make sure that that wound stays closed and stays together. They'll just stay together. And then with any surgery, you have risk for pulmonary embolism, a DVT, basically a venous thrombosis. They should have their catheter removed within 24 hours. I think that is a not a statewide, like a JCO thing, where they don't want UTIs. So that's just healthcare wide. The catheter should be removed within 24 hours if not needed, so that they don't get a UTI. We need to teach them that when they've had the surgery, they, instead of eating the 3 meals a day, it's generally 6 small feedings, and then encourage fluids in between meals. After people have had the surgery and after they've lost all their weight, it's not uncommon for people to lose 200 pounds with this surgery. So there's going to be a lot of extra skin because the skin has been stretched out to actually have like plastic surgery. And it's called a paniculectomy, where they're actually tummy tucking that pannus. So where it's stretched out on their stomach, they tummy tuck it and get rid of that and take care of it. I don't know if a lot of insurance companies weren't covering it. I don't know if they're covering it yet, but I know they weren't covering it for quite a while. My cousins had this, my male cousin, like my brother, has had the surgery as well, and he says that's one of the hardest parts of having the surgery is having that extra skin. All right, so here I get into dumping syndrome. So, like I said, it's the most common problem with like a Roux-en-Y bypass, gastric surgeries. Anyways, food enters the stomach. Um, it's not completely digested because it still has to go through the intestine, but this undigested food enters the small intestine, starting with the jejunum, or in the jejunum. It goes through the duodenum and then the jejunum, but it enters the jejunum really fast, and it doesn't mix with the digestive juices, the chemical digestion. Um, so it pulls water from the vascular system because it's hypertonic. Anytime something's hypertonic, it will pull fluid in. So it's pulling fluid from the vascular system, and people might be hypovolemic, and that's what causes the undigested food, to speed through the body. So when um, people have dumping syndrome, they're not absorbing the nutrients. So like we talked about, what slide was it? Nutritional deficiencies, the problems of a bariatric weight loss surgery. This is part of the reason, because it's not sitting where it needs to be long enough, so then people aren't absorbing all the nutrients that they need. Like I said, symptoms for dumping syndrome, they're going to be nauseated, they might throw up, they might be lightheaded, dizzy, they're going to have tachycardia, they might actually have weakness, and they're going to have some severe abdominal cramping. It's not comfortable. And so when the food is rushed through the digestive system so fast, it stimulates the pancreas to release insulin. So these people that are having dumping syndrome, not only do they have to go to the bathroom right after and things are going through the body too fast, they're also having a huge release of insulin, so they're hypoglycemic 2 to 3 hours later, and then they're trying to eat again in the whole process. It's just a vicious cycle. So they're eating, it's going flying through, they're becoming hypoglycemic. So what do you do when you're hypoglycemic? You got to put some food in your body, and it's just doing the same thing over and over and over. These guys, one of the symptoms that's not on here is they're sweating. Like I said, when their belly's cramping up and they're lightheaded and tachycardia, yeah, they're going to be sweating as well. Treatment, we need to teach these folks to have small, frequent meals. Whether it's 6 meals, whether it's 8 meals, it doesn't matter, but just the small, frequent meals. So maybe the small amounts, they're not getting quite as severe symptoms, but just small, frequent meals. They need high protein and high fats, but decreased carbs, so that because that way, if the more proteins and the more fats they have, if they have dumping syndrome and it's flying through the digestive system, it is absorbing more. We need to teach them not to drink fluids with their meals, so they can have fluids before, fluids after, but when they're eating and taking a drink, that's what worsens the dumping syndrome. So we can teach them to have, so that they're not taking fluids with their meals. We can teach them to lie flat or recline after meals because that will slow down this gastric emptying. Uh, whether they're like sitting in a recliner or they're laying down in bed, either way, it doesn't matter. They'll find foods that actually cause symptoms. Just need to teach them, if this happens when you eat pizza, please don't eat pizza. Kind of keep a list, keep a diary, so you know what triggers it and what doesn't. But try and stay away from foods that cause discomfort. Caffeine and alcohol intake actually increase dumping syndrome. Smoking does as well. And these folks with dumping syndrome, because their stomachs are not producing everything it needs to be, and they're not absorbing everything they need to be, they will be on B12 injections. I think that's everything on dumping syndrome. Alright, so we're going to start getting into the upper GI disorders. Esophageal cancer. So, most people that have esophageal cancer, their first symptom is dysphagia. So they're not able to eat. They're having a hard time eating. You're going to see weight loss because they're not eating as well. You're going to see acid reflux. You're going to see hoarseness. And it's going to feel like there's food caught in their throat or their chest. These are diagnosed with an upper GI and a biopsy. So they'll go in, they'll look at it, and they'll pull a biopsy off of it. Risk factors for esophageal cancer, obviously age. If somebody's been a heavy drinker or heavy smoker, can be esophageal cancer. Sometimes HPV, the human papillomavirus, might actually be the cause of their esophageal cancer. There's a poor prognosis when somebody's diagnosed with esophageal cancer, just because that the esophagus is so thin. Those tumors actually expand and met to the lymph nodes, which are right next to the esophagus. So you can see where it doesn't really have to met too far to be spread to the lymph nodes and then transferred throughout the whole entire body. So I actually had a patient when I was first starting out, and I will never forget it. She ended up with esophageal cancer, and she always complained that there was something stuck in her throat. So I sent her for an upper GI, and I was so new to nursing that I didn't realize that doctors were people too, and they swore. But the doc called me, and first thing he said, he's like, Lisa, you wouldn't believe the shit I just saw. I was like, whoa! Anyways, her esophagus she had cancer, so it was actually between the tumor and the stricture. When she ate, it built up on this stricture and on the tumor. So when he went in there was basically, I don't want to be gross, but like rotten food sitting in her esophagus. And when he tried to get through all that gunky food, because there was only just a very minimum, like she could drink and it would go through, but that's about it. He actually perfed her esophagus. But he said that was the worst he has ever seen. And it was just basically built up with gunk. She didn't live, I don't think she lived another week, but it was just terrible because she basically, before we even knew, she was almost gone before we even knew what the problem was. Alright. So, as you can see, this is just a tumor growing in the esophagus, and you can see where that lady with the food would have gotten built up in there. Plus, she had a stricture as well. So, chemotherapy, radiation, surgery to remove the tumor, and some people might just choose palliative care. Keep them comfortable. Esophagectomy, they actually can take out most of the esophagus. They can actually take out all of it. Just depends on how far the cancer spread. So they can actually move the stomach up. So sitting in the chest. Yeah. These people are going to have cardiac dysrhythmias, dumping syndrome, delayed gastric emptying. So they're either going to go really fast or really slow. Yeah, it's all right. So hernias. I have my notes here. All right. So there's different types of hernias. This one is a hiatal hernia. And hiatal hernias, there are two. So the one shown right here is a sliding hiatal hernia because that lower part of the esophagus can actually um, be put, it can actually go back down into the stomach. So it just kind of slides up and down. The stomach actually goes up and over the diaphragm. I hope that makes sense. I really wish, every time I do a lecture, I'm like, oh, I wish I was in front of you guys, but it would make it a lot easier. There's also one called a rolling hiatal hernia, and that's where the stomach actually comes up and forms a pouch on the top of the diaphragm. It can go back down, it can come back up and sit on top of the diaphragm. So they both can reduce themselves, but generally the one shown is I get them mixed up, sliding, and the one where the stomach pouch actually sits on top of the diaphragm is the rolling. So I kind of explained it already. The lower part of the esophagus that's below the diaphragm, and the stomach actually slides up and through that hole of the diaphragm where the esophagus goes through. Like I said, there's sliding and there's rolling. Rolling has a bigger risk for, like, it's called strangulation. So, let me put my notes here. Strangulated just means that blood supply is cut off from the hernia ring, basically the band of muscle that's on the bottom of the hernia. It's just a pouch, like I said. But you're going to see things like ischemia. If it's a bowel herniation, you're going to see bowel necrosis or bowel perforation. It just kind of depends on where it is. So this could be an actual ischemia and necrosis of the stomach for a hiatal hernia. Reducible hernias can actually be put back in place, whereas an irreducible one is basically an immediate emergency surgery situation. Risk factors for hiatal hernia: obesity, pregnancy, history of GERD, and being a female is actually a higher risk for hiatal hernia, and being over the age of 60. Treatments for hiatal hernias, again, small meals, have them sit in the Fowler's position, have them sitting straight up, so that the food can go straight down rather than get stuck in this little pouch. Like I said, elevate the head of the bed. No tobacco, no alcohol in the spicy foods. Peppermint, chocolate, pepper, caffeine. Bedtime snacks, because they will eat and then they will lay down, and that will cause the herniation to become worse. Weight loss might actually help, and antacids. They don't reduce the hernia back in, but they help with some of the stomach acid pain. For hiatal hernias, they can actually have what's called a Nissen fundoplication. So it just wraps part of the stomach around the bottom of the esophagus so that it can't fit through that hole of the diaphragm. Okay, I'm going to back it up because we don't have anywhere else that, oh, I got to back it up even more because symptoms of a hiatal hernia, actually severe chest pain. People with these actually think they're having a heart attack. They'll come in to the ER and say, I think I'm having a heart attack, and it will be the pain caused from a hiatal hernia. Well, some of the pain will be able to be resolved with antacids, but until that hernia reduces itself or they have to have a Nissen fundoplication, the pain will still be there. But it's severe chest pain that can actually be mistaken for a heart attack. So like a sliding hiatal hernia, you're going to see things, they're going to be complaining of heartburn or regurgitation, chest pain, dysphagia, and belching. So the rolling hernias actually are the pouch of the stomach that comes up and sits on top of the diaphragm. You're going to see a little bit different symptoms. Those are going to be, I can't even read my own writing. I'm not sure. They're going to have this feeling of fullness because their stomach is, they're going to be short of breath after eating because it's pushing on the diaphragm. They're going to also feel like they're suffocating. Chest pain that actually mimics angina. And the pain actually gets worse when they lay flat with both of them, but more so with the rolling. So there are other types of hernias that are not in here, just because of where they're located, but I thought it was worth talking about because they could technically be in the GI system, kind of. The umbilical hernias are right in the belly button. It's either at birth or something they're born with, or it can actually be acquired from like lifting something heavy. So they're actually increasing their intra-abdominal pressure. So the heavier they are lifting causes the pressure to increase and can actually pop things out and make another pouch. There's an inguinal hernia, which is right in the groin area. An incisional hernia, where if somebody's had surgery, their incision can actually herniate. So, all right. GERD. You guys have all heard of this or worked with this. The LES, or the lower esophageal sphincter, also called the cardiac sphincter, is weak and it allows the acid from the stomach to flow back up into the bottom portion of the esophagus. Can actually cause damage to the esophagus. It's called Barrett's esophagus or esophageal strictures or actually esophageal cancer. So once this acid comes up and sits in there, that's what can cause the issues with worsening the Barrett's and the cancer. Symptoms of GERD, obviously that lower esophageal sphincter is weak. Might be a hiatal hernia, can actually cause someone to have GERD. Foods and beverages, we went over this with the hiatal hernia, but like chocolate, peppermint, garlic, caffeine, alcohol, fatty foods, and large meals can actually cause the GERD symptoms to be worse. Smoking will cause it to be worse. Opioids cause GERD. Different types of medical conditions, diabetes, hypothyroidism. Obesity is a huge risk factor for GERD. nitrates, NSAIDs, anticholinergics, calcium channel blockers. They all reduce that lower esophageal sphincter and can actually cause GERD. And sometimes there's just no known cause. Symptoms of GERD: you're going to see pyrosis, which is like, it's heartburn, but it's just like a burning sensation. Um, they're going to have a foul taste in their mouth because the acid is coming further up than normal, so they can actually taste the acid. They might be nauseated. Um, the burning fluid in the pharynx, they're going to belch like significant more than the normal person. They might be coughing because there's irritation in their esophagus. They're not going to have a cold or an upper respiratory infection. They're just going to continually cough because there's inflammation, not inflammation, but their esophagus is going to be agitated. Actually is very common in preemies. Um, you'll see this when they have frequent feeds and they're not gaining any weight. My nephews have it, one worse than the other, and he can literally be laying down after he eats, and he'll get this really terrible look on his face and then start crying. So you can just see that it's basically his GERD acting up. Sometimes bleeding, or the odynophagia, which is painful swallowing, weight loss, early satiety. I can't say that word. And dysphagia might actually cause something a little more serious. But so if they have any of those symptoms, we need to really be looking at seeing maybe their GERD has progressed to esophageal cancer. Treatment of GERD. Treatment is a lifestyle modification. We should teach them not to eat near bedtime because they're going to eat and lay down, and with that weakened lower esophageal sphincter, it's going to allow more acid up rather than if they're sitting upright after a meal. So teach them not to have a bedtime snack. Teach them to keep the head of their bed elevated. Weight loss, because obesity worsens GERD symptoms. Help them to quit smoking if they're a smoker, because smoking as well, like I said, will increase the severity of the symptoms. Small frequent meals rather than 3 big meals, because when they have larger meals, that can cause it because their stomach's so full, it's just pushing the acid up. So small frequent meals, and they're going to learn what triggers their GERD symptoms. So spicy foods trigger the GERD, trigger that pain. They're going to learn to avoid whatever those triggers are. Basically, the meds will suppress the acid, low motility drugs to try and get the food to digest through the intestines faster. Sometimes they might need surgery or an endoscopy to see what's causing the GERD. There is a big risk though, because people will be like, oh yeah, I got heartburn, and start on different types of PPIs or whatever is over the counter. So if maybe they have never had issues with heartburn and now they have it severe and they're like, oh, I'm just going to take a Zantac, it might actually mask. So once they start taking the Zantac, the heartburn can actually, be decreased or even go away completely, but it's just masking it if maybe there's cancer going on. All right, meds for GERD and peptic ulcer disease. So I want you guys to know these because these are very important to know. Antacids will neutralize that acid. So these are things like Maalox, Mylanta. They just basically neutralize the stomach acid there. People can be constipated. They can get diarrhea. Um, since there is so much calcium in these, we really have to watch their calcium levels because they can go have hypercalcemia from it. These are just used for like occasional episodes of heartburn. So maybe somebody has heartburn once a month. Maalox, Mylanta, Tums, I think Alka-Seltzer makes a brand, whatever. But Rolaids, these are just for very, very rare bouts of heartburn. Histamine receptor antagonists, also called histamine blockers, actually decrease the acid secretion. So these are meds like ranitidine and cimetidine and famotidine. These are all generic names, of course. But symptoms or side effects from these meds: malaise, headache, diarrhea, constipation. You're playing with their stomach, so all these meds basically have diarrhea and constipation as a side effect. Then PPIs are called proton pump inhibitors. So it just binds that proton pump and stops the acid from moving into the stomach. These are probably some of the most common ones that we see. Omeprazole, lansoprazole, pantoprazole, which is Protonix. Some of these can be given, or these can all be given PO. Pantoprazole is one that is given IV frequently in the hospital. Again, diarrhea, constipation, side effects of PPEs, and they can actually mess with a person's sugar and make it elevate. Promotility agent, it basically stimulates the GI system so that food and all of that is moving through the GI system faster. And these are things like metoclopramide. Metoclopramide. They cause anxiety, restlessness, sedation, seizures, uh, especially when given IV. It can actually have some pretty nasty side effects. They start with a low dose, but sometimes there can be some pretty nasty side effects. And then there's the cytoprotective agent. So it just acts as a mucosal barrier. So it coats the stomach, the mucous membranes of the stomach. Example of one of these is the sucralfate, and there's really no side effects that they're aware of. So if you guys were to study this table, that would be great. All right, peptic ulcer disease. So basically in peptic ulcer disease, the lining of the stomach, the pylorus, the duodenum, or the esophagus, the mucous membranes, basically, is actually eroded, and there's a hole uh, because of H. pylori. It's a bacteria that some people don't have problems with, and some people do. So it's not. It was actually not discovered too long ago. I guess it's almost 40 years, 37 years ago, 38, depending on when. But H. pylori is actually the cause of um, almost all gastric ulcers, almost all duodenal ulcers. Risk factors for PUD: smoking and chewing tobacco, alcohol, caffeine, stress, um, and meds like NSAIDs or aspirin and steroids can actually cause this peptic ulcer disease. So in gastric ulcers, It's the hydrochloric acid that is actually um, damaging the epithelium of the stomach, even of the duodenum. But stress is a huge risk factor or cause of peptic ulcer disease. But the more stressed people are, the more likely that they're going to have an ulcer. How the two are related, I'm not really sure, but I do know that stress very much causes ulcers. Treatment for PUD. Oh, sorry, it's like 1 o'clock in the morning and I gotta get up at 5. Avoid anything that triggers or irritates the stomach. It's actually very painful. Obviously, it's basically a hole in the stomach. A bland diet, the more spicy the food is, it's going to irritate that ulcer. Um, Hemoglobin and hematocrit are going to be monitored because people can start out with a small ulcer like this, and actually it can turn into a bleeding ulcer, and they can get a big GI bleed from it. Going to be treated with the meds that were on that other slide. If it is an H. pylori infection, generally you're going to see these people on 2 antibiotics and a proton pump inhibitor. Um, they might be on Pepto-Bismol. Uh, so there on that slide with the table, it just says histamine blocker. Well, there's an H1 and H2. So H. pylori, peptic ulcer disease, they're going to be on what's called an H2 blocker, a histamine 2 blocker. But they really need to just monitor their diet, make sure they're not eating anything too spicy, and they'll figure out what their triggers are. I mean, we can teach them, hey, you need to keep a diary and say, okay, I ate this and now I'm having this. So really try and figure out what their triggers are, their irritants. Maybe it's just being stressed out. Maybe it's a certain situation that causes stress. They just need to figure out their triggers and their irritants. Um, Gastric bleeding. There's lots of reasons. Tumors, ulcers, could be gastric surgery that's not healing. Might be caused by, you might see blood in the stool. Sometimes, I mean, sometimes you'll see it, sometimes you won't. But you can do that occult blood test right at bedside. You basically apply their stool onto this little card and then put some chemicals to it. And if it doesn't change color, that's great. But if the outline of the poo turns blue when you put these drops on it, um, that's positive for blood in the stool. They might be throwing up um, blood. They might have black tarry stools. Especially with GI bleeds, one of the telltale signs or the red flags, they're actually going to be throwing up like coffee ground material, and that's old blood coming up from the stomach, and it really does look like coffee ground. So that's another thing, like C. diff. Once you see it for the first time, you won't forget it. If somebody is having active bleeding, they might have a NG tube put in there for lavage to try and clean it out. Also, because blood acts as a natural laxative, these people would be having diarrhea. So the more we can clean out the blood via the NG tube, so they're basically putting fluid down and sucking it back up to clean out. They might be hypovolemic because they're losing blood, so they're going to get IV fluids. They might go in and ligate those vessels that are bleeding. Wherever the bleeding is, they might go in and burn or ligate them. And then oxygen, because if somebody has a GI bleed, that is a huge, huge red flag for anemia, which they can actually go hypoxic from being anemic. Gastric cancer can actually be caused by this H. pylori infection that causes the ulcers. Could be caused by environmental exposures. Anytime that there's a diet high in smoked foods. Generally, this is another one of those cancers that is highly met before it is diagnosed. So there's a poor prognosis when you have stomach cancer. All right. So for stomach cancer, you can take out part of the stomach, uh, gastroduodestomy, just the duodenum, stomach and duodenum. Um, Basically, the further portion of the stomach is removed, and the upper part that is not does not have cancer actually is attached to the duodenum. Then there's the gastrojejunostomy. Um, Same thing. The stomach is attached to the jejunum. Sometimes this can actually be used to treat duodenal ulcers as well. Um, what else? What else? And then there's a total gastrectomy. So this is strictly for cancer only. They won't do it for ulcers or um, PUD. The entire stomach is actually removed. So they attach the bottom of the esophagus to the top of the jejunum. Uh, the biggest issue with this, and like we've talked about when we were talking about the gastric bypass, the Roux-en-Y syndrome, or Roux-en-Y procedure, they don't have enough time to sit in the stomach and actually absorb the nutrients that this person needs, so they will have issues the rest of their life with nutritional deficiencies. Sorry, I'm getting all my notes. All right, appendicitis. Oh, maybe we should. There. Appendicitis. This is the inflammation infection of the appendix. A lot of time the cause is a fecalith, which is a basically hard piece of stool. Actually obstructs the lumen or the opening part of the appendix. Um, when that lumen is obstructed, it actually builds up pressure, and when that pressure is built up in the appendix, it actually restricts the blood flow. So it can either be necrotic, um, it can be infected, you name it, but there's usually some type of inflammation that is causing severe pain. Um, so symptoms we're going to see, they're going to have a fever, um, an increased white blood cell count. They're going to have a shift to the left. So that, remember when we did immune, remember that that just means there's an increased number of immature white blood cells or bands. This just means it's bacterial and there's an infection. The cardinal sign, whatever, of appendicitis is pain at McBurney's point. Now this is between the belly button and the right anterior iliac crest. So when a person pushes down, there isn't a whole lot of pain, but when they let go, it's going to be a rebound pain in McBurney's point. Um, so you can also have a person like jump, and when they hit the ground, it's not so much when they jump up, but when their feet hit the ground, they're actually going to have pain in this McBurney's point. Robsing's sign is pain on the right lower quadrant when the left lower quadrant of the belly is palpated. You're gonna see nausea, vomiting, anorexia, and they're gonna have a CT scan or an ultrasound so that they can look at the appendix. If their appendix is enlarged, then that's appendicitis. If they can actually look and see, because sometimes these appendixes will get so infected or so enlarged that they'll actually burst. So if it's a slow growing infection, you're going to see an abscess in the appendix. If it's a fast one, you're going to see peritonitis, and that can happen within 24 hours. So it's very, very quick. When we're looking at the white count, anything over 20,000 is a huge red flag for a perforated or ruptured appendix, which means all that infection that was hanging out in that tiny little appendix is now floating around in the belly, and they're a huge risk for peritonitis. So, yeah. Interventions. We don't want to give any laxatives, enemas, or heating pads before that they're having surgery, because especially the heating pad will actually increase blood flow to the area and cause the infection to get worse and risk it to rupture. If it hasn't ruptured already, adding heat will just cause it to be a higher risk for rupturing, perforating. Laxative and enemas, if they strain to have a bowel movement or even placing them, can actually cause the appendix to rupture. So we're going to use ice to their belly before surgery. If the appendix is ruptured, these people are going to be on antibiotics before they open up, unless they're going septic, unless they got peritonitis. They want to get some IV antibiotics going before they go in and take out that appendix. Obviously, after surgery, we're going to keep them NPO until they get their bowel function back, whether they're passing gas or even having a bowel movement. But the biggest thing is that they're passing gas before they eat anything. And I told you guys already, complications of appendicitis. If that appendix bursts or ruptures, it can be perforated. Maybe an abscess grows, it'll wall off that infection, but actually it's called an abscess. And then peritonitis if it ruptures. Peritonitis is the infection or inflammation of the abdominal cavity. It can be of an organ, but it generally it's if any type of bugs uh, enter the abdominal cavity, it can actually cause lots and lots of issues. It's the peritoneum, the surrounding part of the abdominal cavity. Symptoms that we're going to see are abdominal pain. Patients are going to be rigid, might have nausea, vomiting, obviously fever. They're going to have tachycardia and an increased white blood cell count. The inflammation of the endothelial lining of the stomach, sometimes that helps to explain it a little bit better. You'll see peritonitis in like people that do peritoneal dialysis at home. This is a huge risk factor, and that is why everything needs to be kept so clean and sterile, because this can happen very, very easily. So, huge risk factor with peritoneal dialysis. If an appendix ruptures, if a diverticuli is infected and it ruptures, maybe they've gotten a wound, like maybe they gotten stabbed in the stomach with a dirty knife, that can cause peritonitis. And even like a gangrenous gallbladder can cause peritonitis. Can be most common causes are E. coli, staph, and strep. So complications of peritonitis. Obviously, it's an infection, but they can go into septicemia or being septic. They can actually go into septic shock. Fluids are going to shift and be pulled from places they shouldn't. So these folks are going to be hypovolemic. Um, can actually cause problems to the kidneys. Peritonitis will actually distend the bowel, so they're a huge risk because uh, for perforating the bowel, because peritonitis can actually cause the peristalsis to slow way down or even actually stop. So the excrement or the poo is actually going to build up in the bowel, so it can actually rupture and cause peritonitis to get worse. Um, Might be respiratory problems with peritonitis because there's increased fluid and there's increased pressure in the belly cavity, and it actually pushes the diaphragm up, so it makes it hard for these folks to breathe. I think I'm going to pause this when I get about halfway and finish it on my lunch break tomorrow. I'm starting to fall asleep. So, diverticulitis. Those little pouches that you see there are um, diverticula, and you can have diverticulosis without the diverticula being infected. Once they become infected, it's called diverticulitis. So, diverticulitis is the inflamed or infected diverticula, which are abnormal pouches in the lining of the colon wall because of pressure. Sometimes when people have chronic constipation, maybe they're not eating enough fiber and not enough fluids over years and years and years, can actually cause these little pouches in the colon wall. Um, they can be big or small. Uh, these diverticula and diverticulosis, um, food, bacteria, what have you, actually get caught in the diverticula. They're trapped, can actually cause the blood supply to be reduced, and that is what will turn diverticulosis into diverticulitis. So, diverticulitis um, is not a medical emergency, but these diverticuli might actually perforate. And like I said, when something ruptures or busts, like the appendix, the gallbladder, um, can actually cause peritonitis. Well, the same is true with the diverticulitis. When those diverticula rupture, that bacteria that's been brewing in those little pouches can actually spill into the stomach and, or not, I shouldn't say stomach, abdominal cavity, and cause peritonitis. Symptoms, we are going to see things like pain, crampy pain, fever, fatigue. They might be bleeding. These folks might be anemic. So, treatment for diverticula or diverticulitis, we want to make sure these folks aren't getting constipated because that will prevent it. The more constipated they are, the more stress put on the diverticula. Might need antibiotics. Um, Broad spectrum antimicrobials like Flagyl with Bactrim or Cipro, so they'll be on at least two of them. They might need surgery if their diverticulitis is bad enough, and that would be a colon resection. So it can be pretty serious, but it is not a medical emergency. Um, Again, because it is infection, we don't want to add heat. We want to use ice. We don't want to give any laxative or enemas because it actually increases the intestinal motility, which can make the diverticulitis worse. Um, Anything that can cause an increase in intra-abdominal pressure, we want to avoid as well, just because anytime that pressure elevates can actually cause those diverticula to rupture. So what do we want to have our people eat? We want them on a low-fiber diet. We want them on clear liquids, some depending on how bad it is. And if it's bad enough, we might actually have them NPO. Yeah, I think I'm going to break for the night. I'm getting sleepy. It is, almost it's 1:30 and I gotta get up at 5. So, I'm going to pause this for now, and I will finish it tomorrow and get it loaded. All right. All right, guys, I'm back. This is so nice. I am sitting in the skills lab, and it is so nice and quiet in here. I don't have any dogs. I don't have any kids. It's kind of wonderful. Not used to having time to myself to record. Usually it's a little crazy. Okay, anyways, inflammatory bowel diseases. The two that we're going to be looking at are Crohn's disease and ulcerative colitis. Oh, sorry, I was up too late trying to get this done last night. Crohn's and ulcerative colitis both cause a chronic abdominal pain, diarrhea, fever, can lead to arthritis, anorexia. Um, but the difference is ulcerative colitis is just the colon, and Crohn's is any part of the GI tract. So it can just it depends on um, where the affected part is. Inflammatory bowel diseases kind of run in families, especially if there's more stress in a person. They might have some inflammatory bowel diseases. Smoking actually increases the risk of having Crohn's, but actually decreases the risk of ulcerative colitis. Both are considered immune illnesses. So, um, medications, aminosalicylates, antibiotics, corticosteroids, immunomodulators, and biological response modifiers. So basically, what they're trying to do is tame down the immune system so that it's not attacking itself anymore. This is just a picture of Crohn's versus ulcerative colitis. As you can see in Crohn's, that intestine is pretty has like a cobblestone appearance, whereas in ulcerative colitis, there's little tiny openings or raw spots. All right. Crohn's disease, like I said, is any part of the GI tract. Has a cobblestone appearance. Most of the affected part of the GI tract will have that look like cobblestone. Can be rectal bleeding if the colon is involved. Fistulas and abscesses are common. Fistula, as you guys know, is an abnormal opening between two organs. So maybe it might be between two different segments of the intestines. Might be a cutaneous fistula where there's an opening up to the skin from the intestine, or even like a perirectal abscess. So yeah, fistulas are common in Crohn's disease. The big difference between Crohn's disease and ulcerative colitis is Crohn's disease cannot be cured. Can be managed, but it cannot be cured. There's nothing in the world that's going to cure Crohn's disease. So, to put it simple, Crohn's is the chronic inflammatory disease of the small intestine and colon. Signs and symptoms you're going to see are diarrhea, and I'm talking severe diarrhea. These people are going to have problems with absorbing nutrients that they need, so they're going to have malabsorption issues. Anemia, not for like blood loss, but because they're not taking in all the nutrients they need, or maybe they're not being absorbed as well as they should be. They might be anemic from the bleeding, but more often than not, it's going to be a nutritional deficiency anemia. So these people are going to be on like folic acid and B12. And they might have fat in their stools called steatorrhea, or they might have bright red blood in their stools. Because they can't absorb what they're supposed to, these people are at high risk for osteoporosis as well. Ulcerative colitis, basically it's the colon and the rectum that are affected. These guys can have up to 20 stools a day. There's exudative and ulcerative lesions, so just meaning ulcers and draining lesions. Um, Generally, it just affects the mucosal layer in the colon. A lot of times you're going to see rectal bleeding with UC. UC does not generally have the fistulas and the abscesses like the Crohn's disease does. Um, Crohn's disease is not a precursor to cancer, whereas ulcerative colitis is a huge risk factor for cancer. And UC can be cured with surgery. Apparently somebody's trying to get a hold of me. I'm going to pause this real quick and check and see what's going on. Sorry about that. My nephews were there. My nephew was at his doctor's appointment, and he is started on new meds, and they needed to make sure it was okay that the meds that they started him on. Anyways, with ulcerative colitis, there's also issues with malabsorption. Can be a non-mechanical bowel obstruction, so basically the colon is not completing peristalsis like it should. They may have hyperemia, where there's actually increased blood flow to the area, causing more blood, causing more inflammation. It's edematous, it's reddened, the areas might bleed. Patients are going to have this sudden, urgent, unpleasant urge to poop, and that is called tenesmus. You guys learned a new word today. All right, so I think that is much on that part. Moving on to irritable bowel syndrome. It's a functional problem. There is no change in the bowel mucosa like with Crohn's disease or ulcerative colitis. It's just the functional problem. Like they get nervous and they have diarrhea. There's an increased sensitivity to visceral stimulation, which increases with stress. So like I said, a person gets stressed out and they have to go to the bathroom right now or yesterday or 10 minutes ago. Might have IBS with diarrhea, might have IBS with constipation, could actually have mixed IBS. So it's either diarrhea, constipation, or it can actually be both. So basically there's no official test for it, but they figure it out by excluding every other test or disease. One big thing to rule out is the lactose intolerant. IBS does not increase the risk for colorectal cancer at all, and IBS does run in families. Again, symptoms are going to be like flatulence, bloating, diarrhea, constipation, rectal mucus, and sometimes these people aren't going to feel like they haven't completely emptied out or gotten all of the stool out. All right, moving on to obstructions. The plumbing is plugged. So there's a small bowel obstruction and a large bowel obstruction. What happens is for a small bowel obstruction, an SBO, which is probably the most common, there is a collection of intestinal contents, waste, whatever, fluid, gas, where this intestinal contents actually blocks the small intestine. On the proximal side of that is the fluid and the gas. Sorry. They just kind of build up on top of that obstruction, that stool, whatever you may have. So anything below it can actually be necrotic, and it can actually perforate when that stool keeps swelling, or the area where the stool is, it keeps swelling. So obstructions can be mechanical or non-mechanical. Mechanical is basically there's an issue with something that is blocking the small intestine that is not the intestine. So it could be adhesions in the bowel wall, in like Crohn's, or even a tumor like in the intestinal lumen. So it doesn't always have to be a problem with the intestines. Non-mechanical is also called a paralytic ileus. You guys will see this. This is more common. It's when the peristalsis of the gut actually pretty much slows down and stops. So that's why there's constipation with that one. Causes for SBO. Abdominal surgery is a huge risk factor for small bowel obstruction. If there's adhesions or scar tissue, intussusception will cause the small bowel obstruction. Hernia, tumor, different things can cause the SBSs. Sorry, the light just turned on in the skills lab and nobody's down there. The SBOs. Symptoms, these folks are going to have like wave-like abdominal pain. They're going to be vomiting. They can actually be vomiting up fecal material. They're going to have abdominal distension and it's going to grow and distend quickly. You're going to hear these high-pitched tinkling bowel sounds. It's not going to be the normal, it'll be ping, ping. They also might be completely absent. You may not hear any bowel sounds at all. They're going to be worn out. Kind of like me today. Anyways, treatment for small bowel obstruction. We're going to get an NG tube down to get rid of that gas and that fluid that's sitting on top of the ball of stool. They may need surgery, just depending on how much the intestine is being affected. If it's completely necrotic, then they're going to go in and cut out part of the intestine. We're going to get them IV fluids because they're going to get dehydrated because now they're not taking stuff in and they're vomiting. So I think that is it on small bowel obstructions. Large bowel obstruction, most likely these are mechanical in cause, so it's something that's blocking it, rather a diverticula, maybe a tumor. Generally, these most happen in the sigmoid colon, close to the rectum. Like I said, things could be that cause it can be like cancer, inflammatory bowel disease, diverticulitis if they rupture or they grow, impacted stool, and then some medications can actually cause a large bowel obstruction. Sometimes the only symptom is constipation, so you might see the cramping and the distension of the belly, vomiting, fecal vomiting is a very late sign. Opioids might actually mask the symptoms of perforation and the decrease in intestinal motility. But people who are chronically taking opioids, their large intestine is actually distended itself. So it's very large compared to the person who's not taking opioids. Treatment, we're going to give them enemas. We're going to try and get them disimpacted. Maybe a surgical resection. They might need an ostomy, depending on how much of their intestine is taken out. So moving to colorectal cancer. Colorectal cancer is common in the U.S. It's it's passed down it's common in families. There we go, familial tendencies. So it can be passed down from generation to generation. Causes for colorectal cancer is anything like ulcerative colitis, like we talked about, because of them destroying the mucous membrane of the inside. They're at a huge risk for cancer. Dietary carcinogens, things that they take in and the body gets rid of. The lack of dietary fiber. If the gallbladder is removed, because there's all sorts of stuff exposing the insides of the intestines. Obesity, smoking, alcohol abuse, and red meat can actually be a risk factor for colorectal cancer. So the first symptom, sometimes the only symptom that these guys have, is a change in bowel habits. Now, it doesn't have to be from having a formed bowel movement every other day to having diarrhea 16 times a day. It's just a change in their bowel habits. So maybe they're constipated and go every third day, and now they're going every day. Maybe it's a little bit looser than normal, but it's a change in their bowel habits. They might see blood or mucus in their stool with colorectal cancer and then have some symptoms of obstruction. Treatment is going to be getting rid of those small tumors. They're going to have them cut out. May need a resection, a bowel resection. May end up with an ostomy, and then obviously chemo and radiation. Pediatric GI disorders. Oh my goodness, I don't know why I'm so tired. Well, I know why, but I shouldn't be this tired. I don't sleep anyway. Anyways, intussusception. So what this is the bowel telescopes into itself. Generally, it occurs in the terminal ileum, the end of the ileum, right next to the ileocecal valve. Generally, we see these in young kids, like 3 months up to 6 years. Can be after an upper respiratory infection. Can be after, maybe having the stomach flu and having lots of diarrhea. Can be from abdominal trauma, and sometimes it just happens. So, symptoms of an intussusception. I think I have too many S's in there, but I can't say it any other way. The biggest thing is that there's this passage of like currant jelly stools. Now compare it to like raspberry jelly. Anyways, it's because it's blood and mucus mixed up, and that's what is actually the stool. You're going to see like colic type pain and vomiting. Treatment, they might be given a contrast enema just so that that telescope bowel can go back into position. If it does not go back into position with the enema, they might actually need surgery, and they'll cut out the part that has folded in on itself. Hirschsprung's disease, see this a little bit more in like the Amish population. It's a congenital aganglionic megacolon. So in the colon, portion of the intestine, portion of the colon, there is no ganglion cells that actually cause the peristalsis. So it's just kind of, for lack of a better term, a dead part of the colon, a dead part of the intestines. Right before that, they might actually, there's going to be a buildup. They might have an obstruction there, so they're going to be distended before the area that has no nerve cells or no ganglion cells to cause peristalsis. So it'll be distended prior to where the affected area is. First symptom we might see is that baby not passing meconium in the first 24 hours. They might need daily normal saline irrigations, might need surgery, might need an ostomy. Just kind of depends on how much is actually involved. Alright, I'm going to pause it, go to the bathroom, get a drink. Hey guys, I think I'm actually going to end it here so I can try and get this posted, so you guys can at least get started on some of the lectures. So I will post part 1 now, and then I will finish this part 2 once I get home. So if you guys have any question on this one, just let me know and I will get back to you. Alright, part 2 coming soon.